but I have the distinct honor of moderating this panel today. So we'll be talking about some topics that came up during the late morning panel, so things around data sharing, security, sharing data, and how to make sure it gets into the hands of the right people. And also we'll take a look at it from the consumer perspective or patient perspective. So first I'll have our panelists give a brief introduction of themselves and what they're working on and their roles, and then we'll have a discussion, and then we'll leave some time for questions. So thank you all again for being here this afternoon, and on behalf of SoCal HIMSS, we appreciate your support.
Thank you. I'm Priti Lakhani. I was on the panel this morning. I'm the Chief Medical Information Officer at Albert Einstein, which is in North Philadelphia.
Good afternoon. Clark Kegley with Scripps Health down in San Diego. I'm the Assistant Vice President of Information Services, and I have accountability this week for enterprise architecture, service delivery, information security, disaster recovery, business continuity, blah, blah, blah.
Hi, everyone. I'm Eric Lee, Medical Director of Clinical Informatics at AltaMed Health Services. We're sprawled out in Los Angeles and Orange counties, and ambulatory healthcare organization. We recently implemented Epic on August 1st of this year. We had signed the contract August 16th the previous year, so we did a big bang implementation, and a couple of things we're working on for the future include remote patient monitoring and telehealth initiatives.
And so all of you are probably at different stages of what we call this digital health journey, as we heard from Dr. Lee, of just recently implementing Epic. So I commend you on that. That must have been a traumatic experience, to say the least. And then other organizations are obviously, using electronic health records in different ways. One of the main functions or capabilities of the electronic health record is really around the patient portal and giving the patients access to all this wealth of data that's being either collected or shared or generated by the clinicians. And so as we think about the patient portal and what value it's had, can you describe what is being used in your organization, and then also what you anticipate using the patient portal for, in the coming years? So maybe starting with Eric.
So we went live with MyChart, which we branded as MyAltaMed on 8/1, and we are steadily enrolling our patients into this. I think what we went live with was bill pay, schedule your own appointment, communicate with your care team securely, request medication refills, and receive test results. What we're looking to do is to enable the video visit functionality within it, and possibly some symptom checking and some triaging to go with it within the patient portal. So I think that's what we have on tap right now.
We're also fairly new to Epic. We finished our implementation about 14 months ago in 3 waves across 5 hospitals and about 36 clinics, a health plan, home health agency, and so on. And in addition to getting standardized on a single EMR and then leveraging MyChart Bedside, and then the rebranded, similar to Dr. Lee's comment, it's MyScripts. So that is the portal that we introduced. And the adoption rate has been growing steadily, around 45–50% overall of our entire patient population. We also decided to implement Beaker housewide and went to a single billing office. So there was a lot of activity associated with all of that work, but we didn't want to lose sight of what was really the first opportunity for our organization to get to a point where we could offer more things to our patients in terms of that digital space. So we actually had about 3 weeks ago our very first true remote visit, video visit with one of our ambulatory care doctors, an internal medicine doc, with a patient that was in Orange County. It went very, very well. We're still struggling, like a lot of organizations, with what do you get paid for, what sort of services do you provide through that vehicle, and so on. But it's very encouraging to have that platform in place so that we can begin to leverage it in that direction.
So we are in a bit of tumult. We are undergoing a acquisition, which is, I think a lot of people have, if you have not faced that, either being acquired or acquiring, prepare yourself, because that's M&As are very, very at the forefront right now in healthcare. So honestly, my job has been to just keep the ship afloat, and because we're being acquired by a health system, it's not final yet, but it should be in the next 6 weeks, that has a different EMR provider than the one we have. So at this point, it's just nothing new, avoiding the shiny new itis and keeping everything afloat. I wish I had something more enlightening to tell you, but I think that in times of transition, just providing stability has really been my job.
And that's a great lead into the next kind of conversation topic I wanted to bring up, is around, as your patients or consumers are going along for this ride, as you will. You've just implemented Epic, you've implemented Epic for a year, you're in the middle of an M&A. They, as consumers, are starting to look outside of your organization for other healthcare options. And so one question is, do you enable the ability for them to use their iPhone to share their Apple Health record ubiquitously? That's one question. And then second, what are some other channels you've noticed from a digital lens that have allowed your patients to, the quote-unquote word is leak out of your system and seek care elsewhere? I don't know if anyone has a strong story to share about that, but I know that's on top of mind for a lot of organizations who are seeing incumbents or non-traditional healthcare people coming in and offering services like instant prescriptions via a online visit or telemedicine visit, or getting your medications filled via drone or some other delivery service that's outside what the insurance plan will cover, et cetera. So just wanted to see if you guys have noticed that and discussed it internally a little bit.
I actually have a name for it. We call them sniffy lubes. So if you think about what CVS and Walmart and other organizations are doing, they're going after really the low-hanging fruit that has a return on the investment. No one is going after our ED business for a whole bunch of reasons, because the financial model doesn't work. So if you think about the whole M&A activity and you extend that out a few years, they begin to slice off pieces of your business that they want, and they leave what they don't want. And that's a pretty scary thought if you think it through in terms of where we might go. So how do you compete with that? So one of the things that we've done at Scripps is we've opened up 14 what we call express clinics. So it was taking underutilized ambulatory space and then leveraging that for those low acuity episodes for new patients, for existing patients. And we've heard the concept everywhere, right? You can come in and for $35, $40, you can see a mid-level, right? And the advantage to doing that for those low acuity episodes is if you've got something more dramatic going on with you, we can send you across the hall versus a CVS or a Walmart who's going to say, well, go see your primary care or go to the ED right now, or that kind of thing. And then in terms of the first part of your question, Alan, around patients and what they're doing, I think back to that M&A concept. Whether we like it or not, we're under attack as an industry, and we're under attack from our own customers, and we're under attack from those companies that would slice off pieces of our business. So why not just embrace that and become a player in the set of activities there? Because if we don't, we will be the ones that get acquired, to Doctor's point earlier. So it's a little frightening. I used to say that healthcare on a given day is 10 to 15 years behind every other industry. I think we're beginning to catch up. If folks don't embrace that journey, they're not going to be around for a long time.
I think what's interesting is it is interesting to look at it from the perspective of the apps coming in, but actually for me, the bigger problem is the patients want to bring me their information, right? And I don't need all your Fitbit data, right? What I want to know is what's bothering you about your data. And so the intake, I think it's really easy to discuss sort of these esoteric topics, but honestly, for me, it's the day-to-day of if we're going to go to an open chart system, what's the delay? Is it a 48-hour delay on critical or cancer-positive results? Is it, if we're going to allow Fitbit data or your blood pressure cuff monitoring data to come in, who's going to be the proxy for the physician that actually combs through the data and says, it looks like every Sunday at noon you have a spike in your blood pressure. Okay, what's the real problem? Oh, you have your grandkids over after church. Let's make sure you don't have a stroke then, right? That's the sort of information problems that I have to solve.
I think I just want to say that I think AltaMed Health Services, we were probably at least a decade behind everyone else. Okay, so we had a previous EHR, we had a patient portal that wasn't very widely adopted or accepted, and if you are familiar with federally qualified health centers, they're based on a return visit, right? All visits have to take place within the 4 walls of the clinic for you to get reimbursement or to get paid. So we're trying to move from this volume to value-based care model, which is even tougher because we don't get the same rights and regulations that the big boys do. So an example would be telehealth reimbursement or remote patient monitoring reimbursement. FQs are still excluded from a lot of these things, right? So we still have to have a patient come into a clinic to see a specialist located at another site to get reimbursement for a telehealth visit. And so those are some of the challenges we're facing is, the devil's in the details. You really got to look at the regulations and the law and make sure you're working with your attorneys and making sure that what you want to do is going to work for you and provide value. I think another example is that, I'm just going to throw it out there because this is, to me, it's still mind-boggling, but I think, about 40% of our patients prefer Spanish, okay? And we were told that my chart is available in English and Spanish. And yet, when you go to the 2nd and 3rd level within the patient portal, it's not in Spanish, it's in English, okay? So that right there is a challenge that we're facing in that we have to work with Epic and their developer team to make sure that all the portions are translated accordingly. Because when you say it's in Spanish, it should be in Spanish, right? They shouldn't have to choose a drop-down menu and try to then figure out what does results review mean, or schedule an appointment. They may know it, they may not, or you're going to have to get a friend or a family member or someone else to help you. So those are some of the challenges we're facing. We're trying to get the entire portal translated into Spanish. I think a recent success that we had was that one of our board members he's a patient, he was at the board retreat and was just screaming how happy he was and showing his test results on his iPhone and saying, this is like, some of our board members see it. They know where we need to be. And we're trying to catch up to everyone else, right? So we know that with making that available and making it widely available for all our patients is a game changer for us. So I think we have to start with some of our small basic steps just to get where we want to be.
Just one more thing. One of the things that I always caution my leadership when they want to consider letting data in or bolting on an app, I always say everything's discoverable. Everything's discoverable. If we bolt on this app, are we prepared to accept the liability of the information that we have purview over as a result of letting them come into our organizational EMR? So that's usually a showstopper.
Just to comment on that, Alan, I think that's such a great point. There's that difficult balance between how much data is valuable to ensure that the patient gets the outcomes they need and want, and the provider is able to make good clinical decisions based on a deep enough understanding around that data versus all the potential bad data that can come in from a variety of sources. And then what are the accountabilities, right? So from a legal medical perspective, a compliance perspective, a risk management perspective, there's dozens of issues to consider there. I'm a firm believer, as an old integration guy, we present boatloads and create boatloads of data in healthcare. What we don't do is a great job of creating information. Right. And my opinion is data with context is information, and that's what providers need, and that's what patients need, and that's what anybody that's going to evaluate that data really needs. So how do we get to that point where what's really valuable and pertinent is in the hands of the people that have to do the work with the data? And your CEO needs data differently than your practicing physicians need data, or even your patients. I think there's got to be a bit of a really sort of blowing up the model at some point here, and I don't think it's that far away for us, where you consider the regulatory issues, the legal issues, the health information issues, and what the patients are demanding and what the providers are expecting to be able to provide quality outcomes. I think there's a reckoning that is coming, and I think it's a pretty big reckoning that is going to change. Someone asked a great question earlier in one of the panels about transformation and the patient's role in that. And again, I think whether we like it or not, they are driving a lot of that change. And I think it has the potential to be really, really good if we can tie those other aspects to it and try and solve that problem more in a way that's a little bit more comprehensive than the way we've traditionally done it as an industry.
May I? Yeah. So one of the things that I think is important for all of you here is the language that the administrator speaks is different than the language that the CEO and the CFO, and they may be like the same romance languages, but boy, the physicians speak, you know, Sanskrit compared to the French and Spanish being spoken at the leadership level. And so I think that the reckoning, you're right, it's absolutely coming. Maybe we can soften it a little bit if we can translate and really convey each of the vernacular. So, for example, I'm sure you have this. I have people coming up to me all the time, and to your point, saying, this is a priority. And I'll say, I'm going to put my CFO hat on. Tell me how this is going to save me money. Or, I'm going to put my CEO hat on. Tell me how this is a good strategy for future growth. Or, and the physicians are always at a loss, but it's the right thing to do. So, you know, I have 60 other things that are saying the same thing. I have to take your idea and sell it to all these people. Can you help me? And part of that is learning the language.
So I heard from all of you very specific examples of how we have to kind of meet our patients or customers where they are. The language, the ability for them to access their data, their ability to be mobile. But I see a conundrum here where we have patients that also don't want to share their data. There was a recent, security breach around how did a company like Google Health have access to all these records without patients' permission, and they've developed this new platform based on using their software to help improve healthcare. So patients are now reluctant to probably sign away the rights to their data. But then in order to really give them that custom experience, we have to go to where they go and meet them where they want to be met. So we have to understand their consumer preferences, their language, their chronic conditions, what medications they're on, where they live, if they have transportation. And in order to give them that best experience and for the CFO and CEO to make those strategic decisions about where to take their health system, we need that data. But I think what's happening recently with the EMR as an example, you have way too much information now. We talked about this just earlier about what information do we really need. And there isn't enough human FTEs for any organization to cull through this data, be it the patient satisfaction scores or clinical results or remote patient monitoring. So have you seen anything that's giving us the ability to kind of navigate through this sea of data, to still deliver personalized care that's high value, but do it in a way that's cost effective and can help organizations continue to deliver care, because without a margin, there's no mission. So we have to find a way to kind of breach these two areas. So I don't know if anyone has any examples or stories to share.
I think, great set of questions, Alan. I think that part of the reckoning for us is to accept one aspect of what patients do with their data, and I think you've heard a few times today, and we would all agree in this room, I believe, that it is the patient's data, no matter what. We use that data for a variety of different reasons, but at the end of the day, it's their data. But where's the accountability if that patient is sending their data to my organization? Because what happens is the risk shifts entirely to the organization and ultimately to the people that use that data. But where is their accountability for the patient who may very willingly have said, I'm going to provide my PHR data, or I'm going to, whatever, whether it's Apple or Google or whatever vehicle they use to collect their data online, and if they freely make that available to a healthcare organization, theirs or others, there has to be a shared risk model attached to that. That is so completely different from what we do today, but it is true in every other industry where I am freely giving Chase my personal information because I trust them with my banking and financial information. And while they certainly have financial laws that impact them, I'm simply stating that the laws that govern our industry today are pretty antiquated. And they're due for a refresh, in my opinion, so that we can approach this in a partnership model that is different than what we do today. Because I can give you every aspect of my information, and if you let it get out, that is entirely on you. And what work did I do to ensure that you were going to protect my data? I'm not saying that we shift the blame entirely to the patient. I'm saying that that has to be a shared model, and our set of regulations and guidelines around this are overdue for a change. And until we get there, I think we're just going to have different variations of what we've been trying to do as an industry, and we know that's not working. We know in today's marketplace with the demands of consumers today, it doesn't work. So I think it was Einstein that said it best, keep doing that same thing over and over and over, and we know what happens. So.
From just thinking about this, I think, so for patients that don't want to share their data, we have our fair number of those types of patients too. They may be undocumented. We're one of the health centers participating nationally in the All of Us initiative to try to enroll patients into the NIH database. And so we have patients that are afraid or are reluctant to share their data. So you have, you have that set of patients that you have to contend with and figure out how you're going to gain their trust so that they are willing to share their data with you. And then from the perspective of what data are you willing to accept? So for example, social determinants of health, right? You hear this is such a huge buzzword nowadays, and what are you going to do about it? So, within our EHR, we have this beautiful social determinants of health templated out, and it's very consistent with Institute of Medicine guidelines and PREPARE. And yet, what are you going to do when you have all those responses if you can't provide resources or act on it, right? And so, obviously change management is one of these things where it's very difficult because the technology is really easy to roll out, but it's just, can people do all that work, all this new work that's cut out for them, and then be able to act on it while somebody's rooming a patient? I mean, so we have to roll it out in realistic, manageable chunks. So, we haven't expected the entire social determinants to be addressed. But that has to be part of your strategy in terms of how you're going to roll it out, because I think it has to be done in manageable chunks. And you have to build in the resources so that people can act on it. They get printouts or they get referred right away, right, to a social worker in the clinic, down the hall, so that they are able to do that. And so that's some of that where we may not be prepared to receive the data. We haven't made it part of our workflow. But when you do, you have to plan for that so that you're ready to go.
I agree with my colleagues. I think that this is something where I really celebrate the small victories, right? Having a care coordinator in each of the PCP clinics doesn't seem like a huge digital transformation, but the amount of improvement we've gotten in engagement has been significant. This goes back to, I think, an earlier question. Unfortunately, there is not going to be a large leap. These are all incremental, small changes, and we celebrate every single one of them because we've reconciled ourselves, right? To there isn't going to be some large sweeping improvement or even mandate for improvement. That's going to be carried out perfectly. So just like everything, I think with digital transformation or with technology or patient engagement, it's a PDSA cycle every single time.
Great comments. And so I want to shift gears. We touched upon kind of the legal implications around data sharing and privacy. And so in my role at GYANT, I'm the chief medical officer, and we are a software company trying to sell software to health systems and health plans. And what we offer is this ability to engage their patients through an AI conversational platform. However, all that data will kind of filter through us first. And I think we heard on the previous panel around how do you keep track of patients when they have this episodic care, but in between they have these urgent care visits. They go and see a provider via a online telemedicine company, or they go to their pharmacy and buy medications that weren't prescribed by their PCP. And so we get a lot of pushback from health systems like, well, we can't, how are we going to protect this data that you're gathering on our behalf? And I think that really throws a wrench into this idea of innovating and making incremental improvement, because we're never going to necessarily solve that problem right away. And I think a lot of organizations don't like that risk of being able to expose themselves to a potential breach or a liability lawsuit, or just patients expecting that you went to Quest, you had labs, a critical value came in, and you're expecting Quest to send it to Scripps. Scripps maybe doesn't get it, or they get it, it's in the EMR, but there's no one there on the weekend to look at it, and then the doctor gets a call saying their patient had a critical value, why didn't you act on it? So are there any things that you guys have learned in your experience working across your organizations that have allowed you to take those leaps of faith with kind of different technology partners around this concept of gathering more data, interpreting more data, but also giving patients better care? I think that ultimately that's the goal. But unfortunately, there's these legal implications and liabilities that get in the way sometimes.
I think price transparency is a great thing, but I think there's studies out there that also show that access, availability, and loyalty matter more than the brand itself. Okay, so if you're Cleveland Clinic, I mean, that's a wonderful brand. Mayo Clinic, wonderful brand. But if they're going to charge 5 times as much as my community hospital that was awarded, that won all these accolades and awards for quality, safety, and I'm pretty much going to go to my local clinic, right? Unless I have that zebra, that really rare autoimmune disorder that I have to go to Mayo Clinic for. So I think you're going to find that, and I think so. It really goes back to the patient care, the patient satisfaction scores your organization receives, that loyalty and that connectedness that they feel with you. Are you able to offer that? And if your prices, I suspect if your prices are middling, you're still going to be fine. So.
That's great. You guys all share the same opinion about this. It's interesting because the American Hospital Association, the American Hospital Association for Pediatric Hospitals, and some other large organizations are all suing the government for this rule. And you can see that must be a conflict of interest here in terms of what is right for patients versus what is right for organizations and the financial profitability of being able to hide some of this data. And so that goes back to the data, a different type of data, obviously, we've been talking about, but this ability for healthcare to improve upon itself, and I think it does require the ability to have this data readily available, analyzed, interpreted, put in through different lenses, because the CFO looking at data is not going to have the same perspective as the chief nursing officer or the patient experience officer. We have different care settings, federally qualified health clinics, high prestigious organizations like the Mayo Clinics and Cleveland Clinics and Scripps, and they're all going to have different perspectives on how this data, what comes out of that analytics. And so as you think about all of this information, and if you could change one thing in your organization now for managing all of this data, and either the ability to get the right insights out of it or encourage your leadership to make decisions based on this, what we call kind of evidence-based approach, because they have tangible information or numbers or prices that they can act on. Or how can you use this to empower patients to push for that change that Eric mentioned about, I have the data now, I expect my health system or my doctor to now respond to me. Because without that, we don't know what we don't know. I don't know how much my surgical procedure costs them. I don't know how much it would cost if I went to a competitor or decided not to use my Kaiser Health plan and go to UCLA or down to UC Irvine, maybe there's a cash price, and there's companies out there that are doing this. They're leveraging doctors who are willing to do procedures without accepting insurance. They'll just basically make some profit off of their cost, and that actually is a benefit to the patient because they end up paying less without going through the insurance. So just wondering if there's something that if you could change now around this idea of data transparency and data collection that would really help improve how your organization functions and operates. Anyone can go ahead. It was an easy question, right?
Yeah.
I think that's a hard question. One thing, I think for me, as a technologist, and I've spent my entire career in healthcare IT, so I've seen some of the gyrations that we've gone through as an industry. It would be a bit of a blanket, but sort of all-encompassing statement, Alan. Everything we do should be laser-focused on what's best for the patient. Now, attached to that are 1,000 things that we've talked about and other panels have talked about today. But we worry about regulatory, we worry about legal medical, we worry about health information, we worry about all these really important things. And our CEO likes to say, we don't pay a whole lot of attention to what's happening in Sacramento and DC. We monitor it, and we have teams of people that do, but we really can't change what happens at the federal level or the state level with some of those decisions. But we can change what we do and how we do it relative to taking care of the patients. And if we remain focused on that, and that's going to require some organizations, and we heard some of this earlier today, it's going to require you to look at your projects list and say, that's a really great idea, let's not do that. And you're going to have to say that kind of over and over and over because we try to do too much as an industry. And we've all got governance structures, and we talk about, what are the gates that those governance structures navigate when they evaluate whether we should do this thing, whether it's a new EHR or something else, and we think regulatory and legal and everything else. How about what's best for the patient? Start there and stop there. And you might find yourself in a very surprising state down the road where you're doing less, and it's more impactful, and you can actually track it, and the outcomes are better. And I think we have to be better in terms of asking our patients what they want, and did they actually get it?
I was taking notes while you were asking that question because, well, first of all, instead of one, can I have two things? And if I can have two things, the first question, these are very practical approaches, but when my providers or when my administrators come to me and they say, I want a report, I cringe. I don't know how many of you feel this way, but the first question I ask is, what are you going to do with that information? Justify to me that I'm going to write the code to pull this report. And the second thing is, you don't want a report, you want a dashboard. You don't want to, you think you want a report. And they'll say, oh, an Excel spreadsheet will be fine. And I said, you understand we have branching logic and that's going to be 18 Excel spreadsheets, right? And they don't. So what I always say is, tell me what you're going to do with it. And you don't actually want a report, you want a dashboard. So I would encourage you to educate your, both your providers and your administrators on the difference between those two things. And then the second thing, as far as what's good for the patient, I would blind any payment information to all my providers. So we don't know if they have health insurance or don't. We don't know if they're Medicaid or Medicare, because then everyone has the same access and gets treated the same, and that's what I would do.
So I agree with my colleagues here. I think, from my perspective, I think what's best for the patient, but also what's best for the care team. And I think, burnout is heavily talked about. I just read over the weekend an article about Mount Sinai residents in which there have been multiple physician suicides. And every time there's a physician suicide, it's not investigated. Yet, if there's a patient safety outcome or near miss or a patient death that could have been avoidable, you can bet there's going to be a huge army of folks investigating what happened and why. So I think if this is going to be sustainable, you have to try to keep that entire flow of how things are to happen and what the impact is operationally. So to me, I think the most important thing always remains, how can you make this workflow better, right? How can you make it more efficient and less burdensome on the provider, on the nurse, on the front desk staff? Because I'm telling you, with data, there's more and more questions to be asked, more and more data points to collect. Obviously, report writers and folks on the back end have a ton of, let's query this and let's adjust the logic as such so that the report or the dashboard is meaningful. But I have so much data there. And is there value in asking this question and those questions? And so I think that's, that's the one thing I would do, is just really continue to maintain that focus on how to be as efficient as possible and not as burdensome as we are today.
So thank you all for this great, engaging conversation and sharing your stories and thoughts from your experiences.